This is Dr. Lovell Jones, who is a candidate for our signature hire position in Health Disparities and Health Equity Research in the department. I want to take just a moment and tell you a little bit about Dr. Jones, and I think you'll understand why we're so excited to have him here visiting with us today. He has this huge CV. I really can't tell you all of it, or we'd be here for 2 hours just in and of itself. So let me tell you a little bit about him. Currently, he's the director of the Dorothy Height Center for Health Equity and Evaluation Research at the University of Texas MD Anderson Cancer Center in Houston. He's also the director of the Reproductive Biology Program in Biomedical Sciences at the University of Texas Health Science Center in Houston. He's a professor in the Department of Health Disparities Research and in the Department of Biochemistry and Molecular Biology, both at MD Anderson. And he's also a professor in the Graduate School of Social Work at the University of Houston. He got his PhD from University of California at Berkeley in zoology with an emphasis in endocrinology and tumor biology. And he did his postdoc at the University of California at San Francisco in reproductive endocrinology. He's published over 120 peer-reviewed papers, articles and book chapters, and has been awarded over $25 million in external funding over his career. He's very influential on a national level. He's been a long-time reviewer for NIH, DOD, EPA, a variety of other organizations. He has many, many honors. I'm just going to highlight 3 of them that just came from 2012. He was named a distinguished teaching professor at UT Anderson Cancer, MD Anderson, so we're expecting a good talk today. He was awarded the Unsung Hero Award in Health by the National Association for the Advancement of Colored People, and he was named one of the 180 living African American scientists of legend by the National Science Foundation. So we do have, for some of you that have just come in, we do have a couple of empty seats right over here on the right side. So in the meantime, please join me in welcoming Dr. Lovell Jones.
Thank you. Sometimes when I hear those introductions, it's like, I am married, I do have children. So I do other things. What I'm going to try and do in the next 50-some minutes or so is to give you a snippet of where health disparities is and the complexity in terms of addressing health disparities. And if it looks like I'm running through slides, it's because I do have 361 slides. No, but I do have a few. Because health disparities for so long has been siloed, and because it's been siloed, it really has not been addressed. And so I want to thank the committee, Dr. Lightfoot for the invitation, Rick and the hosting of me. I noticed that I should have changed the heading of this, but I just gave this talk a couple of days ago to a group of nurses. Since this is a class, you will be quizzed. So these are 5 questions that you should think about. Hopefully you will have the answers to the questions and you all get A's at the end of the session. But first of all, who suffers from health disparities and has past efforts resulted in a reduction? What additional data do you believe should be evaluated, and are additional questions raised in order to help determine the most effective course or courses of actions to address health disparities? How much do you think health disparities cost this nation? And should the term be used health equity, going towards a positive as opposed to health disparities? Think about your perceived views prior to this lecture, and then think about them after the presentation. Think about them again in terms of the cause or causes of health inequalities. Were you surprised by your perceptions? Yes or no? Following this lecture, take some time to outline 2 to the 4 approaches you think you can do to address this issue and form teams to implement them in your communities. Too often we think somebody else is going to solve our problems in terms of doing this. So we're all on the same page. This is how NIH defines health disparities: differences in the incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist among specific population groups in the United States. Some of you probably have seen this before. This was a statement made by Dr. King now over 48 years ago, 47 actually. Of all the forms of inequality and injustice in health, is the most shocking and inhumane. The key to that is he made it 47 years ago. And we still are at this point in terms of looking at health and health care. But this is the biggest issue. The Journal of the American Medical Association, not your liberal publication, one of the most conservative journals that you can get into, 4 years ago, said that despite all our efforts, despite all the money that we've put into this era, we still have not made one major difference in terms of health disparities. Not one major difference. I say we're in the era of what I call the health disparity pimps. We've gone through the era of the sickle cell anemia pimps. We've gone through the era of the infant mortality pimps. And we're now in this crucial phase of the health disparity pimps. But this is the most serious to the survivability of this nation. This is the most serious to the survivability of this nation for everybody, no matter what color you are. Here are the problems, and I will try to go through them. I may have to go through them very quickly because I could give a whole lecture on each of them. But here, as I perceive them, and my perception is my reality. As much as your perception is your reality. Here's my perception and my reality. There's a problem with regards to immigration and health. If you look at undocumented individuals as criminals, we've changed the way we've looked at health in this nation. We've gone from infectious disease to chronic disease as a model. When this nation looked at chronic disease as a model, there was no difference whether you were green or polka dot. If you needed to be immunized, they would find you on the deepest part of a reservation because your health was as crucial to my health. Because I never knew when I would come in contact with either you or your family member or a friend or someone. And so I had to make sure that you were immunized. Because if I didn't make sure you're immunized, I could catch that disease. For chronic diseases, we don't have the same connotation. We think that just because you develop cancer or you develop diabetes or you develop hypertension, that's not my problem. But no one thinks about the $50 box of Kleenex in the hospital or the $25 pair of slippers that you can get from Walmart for $2. That's because I don't care about your health. That's a direct correlation because we don't think about the health of other individuals. And that's probably as deadly to you as getting a disease. Health is not a national priority. I'll show you why. Disparities in health in America, are they real? Yeah, that's a good question. Race is a biological construct, is a blessing and a curse. Is race a biological construct? And racism, racialism are not resolved issues. You probably know about race, you probably know about racism, but what do you know about racialism? Mr. Rickey, do you know that the integration of baseball was not done for social issues? It was done primarily as a business relationship. When Branch Rickey was going after the contract of Jackie Robinson, remember, baseball was a slave industry, indigent servants. If you wanted somebody, you had to buy their contract. They just couldn't negotiate with you. And so when Branch Rickey went to the owners of the Negro Baseball League, and remember that most of the Negro Baseball League owners were white. And in fact, most of them were owners of the Major League Baseballs teams. And therefore, you were competing against each other. And they had a cash cow. The Negro Baseball League was a major cash cow. And so do you want to get rid of your cash cow? No. And so every time they would make an offer, they would raise the price. And they knew how much money the Brooklyn Dodgers had. They were all owners. They knew how much they had. And so think about this. Branch Rickey, to actually get the contract of Jackie Robinson, had to go down to Wall Street bankers, because they were investors in the Brooklyn Dodgers. Now think, a group of white guys, he's coming in and he says, I want to buy the contract of this Negro baseball player to put him in white baseball. Here's what they actually said to Branch Rickey. These are the exact words. Mr. Rickey, if you're doing this as an instrument of social change, you're not going to get any money from our institution. However, if you're telling us it will make the Brooklyn Dodgers stronger, we will support you and we will have a business relationship. And they asked him, could he guarantee that the Brooklyn Dodgers would be in the World Series within 5 years? The rest is history. It was a money proposition. And so what I'm saying to you is to address health disparities. If we continue to talk about it as a social issue, and it is a social issue, we're not going to get anywhere. As a good friend of mine, very wealthy, said to me, my heart is with you, but my wallet is not. If you continue to talk about social issues, it does nothing for my business. And so I have to get things along those lines. Dr. Dorothy Irene Height. I put her up here because few people, how many Deltas are in the audience? Okay. Do you know what her contribution to science is? Can you tell me? Okay. She wrote the Belmont Report. Anyone know what the Belmont Report is about? If you do anything with regards to institutional review boards, the formation of the Belmont Report is its underpinning. She was the main author of the Belmont Report. Now, people who don't know the history are doomed to repeat it over and over again. And in her last book, I happen to have been mentored by her for the last 25 years of her life. Amazing woman. To give you a short snippet of it, when President Obama was holding his first meeting on women's health, she couldn't attend. He looked around the room and he noticed that she wasn't present. And so he asked one of his aides to go and get her on the phone and apologize to her for holding the meeting without her presence, and asked if there was anything he could do for her. The response that came back from the aide is postpone the meeting. He postponed the meeting until she could come. She was advisor to 5 presidents on women's issues, on civil rights issues. You know about the Big Six, right? Well, she was the 7th. If you've ever seen the picture of the March on Washington, she is that woman leaning out, looking at Martin Luther King. And she said the reason why she did that was that every time there were photos taken, if she was on either end, she was nudged out of the picture, and there's only the 6 that were taken. So most of the pictures are of the 6. But she was the 7th. You want to know who the scientist is? This is one of my mentors. But who is the other person? Not Charles Drew. Not Booker T. Washington. Not George Washington Carver. Let me also say to you, give you a hint, which is not a hint, but it's a hint. This person laid the foundation for the Human Genome Project. Was one of the founders of Woods Hole. Okay. Ernest Everett Just, born in South Carolina. His mama sent him to New Hampshire for school because he couldn't be educated well in South Carolina. Was one of the first African Americans to get an English degree, any kind of degree, from Dartmouth. Went back and got a PhD. Was a Spingold Award winner. Did a fellowship at the University of Chicago. Actually helped set up the American Society of Zoologists. and was inducted into the Washington Academy of Sciences. Actually started the Department of Zoology at Howard. And I say we sometimes do to our own what sometimes we think others do to us. He died in 1941 primarily because he had a hard time getting care. And he had a hard time getting off his job because Howard refused to pay for him for sick leave. So he died in his office. And this is what his mentor wrote about him when he died in Science magazine. Science being one of the top journals. It still was a top journal at that time. He says, an element of tragedy ran through all Just's scientific career due to the limitations imposed by being a Negro in America, to which he could not make any lasting psychological adjustments in spite of earnest effort on his part. His first job, he had to go to Germany. And that's how my mentor met him, because he happened to be my mentor's mentor in Germany. And actuality, my mentor got a lot of the awards he got, and also said he got those awards based on Ernest Just's work, because Ernest couldn't get the awards. Do you know who this person is? So it's just not racial, it's gender, whole bit goes through. Rosalind Franklin. You know who Rosalind Franklin is? She's the person that identified DNA. Watson Crick, in terms of the book, said they did. She was the one. They actually went through her garbage and actually stole her micrographs and published on that. The only reason why it wasn't Rosalind, it wasn't Franklin, Watts, in terms of, and Crick in terms of the Nobel, is that she died. And Nobels are not given posthumously. And so she got kind of washed to the side. A friend of mine gave me this. He says, every time I've done something worthwhile in my life, I've caught hell over. You know. But before you think, I talk about this with a chip on the shoulder. This is one of the models I helped develop in terms of hormonal carcinogenesis that's now used worldwide in terms of looking at the effect of hormones, looking at the effect of chemical agents in terms of carcinogenesis. Several years ago, I ended up on the cover of Science magazine. How many of you know about HER2/neu oncogene? HER2/neu in breast cancer, the treatment of breast cancer and control of breast cancer. This is HER2/neu in ovarian cancer. I joke and say, if you've seen the movie on HBO with Dennis Slayman, who's done HER2/neu in breast cancer, I'm the black guy that kind of floats in the back. I don't have a speaking part. But the other one is probably what I'm most known for. That's for the Biennial Symposium on Minorities in Medical and Served in Cancer. That's me when I didn't have the gray beard. That's a good friend of mine, Guy Newell, who was then head of cancer prevention and control at NCI, and then actually came to MD Anderson. And I still work on this. I still do molecular biology. I do molecular biology now with my students. As my daughter used to say, the happiest she's ever seen me is when I'm in the lab. The last time I was in the lab really doing stuff was about 3 years ago. I was hoping to retire to get back to the lab, but I'm still. What about data? As Tip O'Neill used to say, all politics are local. I say all data is local. Have you asked where data comes from? When the American Cancer Society say cancer rates are going down, and you say, oh, wow, that's good. Or you see that infant mortality is going this way, and you say, oh, that's good. Have you asked about, is it occurring in your community? Or is these are national figures? Okay. The purple are African Americans. We haven't drifted too far away from the plantations. About 68% still stay in the South. When people say they have concerns about immigration, I say, what border? That used to be Mexico. Still is considered, in terms of families, going back and forth. In fact, in Arizona, a good percentage of that border is Indian reservations that go on both sides of the border. So in terms of Indian tribes and families. Oh, you're Mexican. You can't come across the border. You can't come to dinner. Yeah, I mean, we need to think about that. But in terms of data, you know, surveillance, epidemiology, and end results, SEER, which is where we get most of our incidence reports from. Okay. The colored states are where the SEER registries are. Notice something unusual about this graph? Texas doesn't have a SEER registry. Louisiana used to. It's building it back up again, but Katrina took care of that. Mississippi doesn't, Alabama doesn't, Florida doesn't, South Carolina doesn't, North Carolina doesn't. You know, so when you see that SEER data, I guess the Mexicans or Latinos in New Mexico are the same that are in Texas, right? Same population, right? That's what you're reading. Okay. You got to ask those questions. If you look at this in terms of African American breast cancer, and that's one of the things I do for a living, or I used to do for a living, or I kind of do and have others do. Look at where the incidence data comes from. Detroit, LA, Atlanta, San Francisco, and Oakland. 80-some percent, 89% of all the incidence data comes from those sites. So I guess, you know, Texas is the same as Detroit, Los Angeles, Atlanta, San Francisco, Oakland, right? I guess we have the same incidence data, and you know, we make that judgment because we see it in the newspaper and we say, wow, that's great. And this is not just racial, you know. Appalachia. Anybody know why Appalachia is the way Appalachia is? Why, you know, this is all Scotch-Irish. Okay, the majority of these people are Scotch-Irish in origin. Okay. Ever wondered why, you know, some people say it was because of the moonshine that they hated. They hated revenuers before the moonshine ever came into existence. You know why they hated revenuers and that sort of thing? They were placed here. They were placed here in the 19th century, 17th, 18th, and 19th century. And they were placed here primarily to prevent slaves from escaping. Didn't know that, did you? Person, black, going into a 99% white area, stands out. Whoop. Whoop. Can't escape. So because they were confined there by Union troops, they don't like government because they see government as the oppressor. And that translates into a lot of other things, okay? But this is where data comes into play. Here's SEER data, okay? Overall, whites and blacks, okay? You would say, well, you know, those black guys in Kentucky have a problem in terms of the difference with regards to cancer, lung cancer, cervical cancer. Those white people are doing a little bit better, doing a whole lot better. But if you take 3 poor counties in Kentucky, that's 99.999% white, and you go, whoa, they got a problem. That's local data. But if you went on this data, in terms of addressing disparities, you would say, we got to do it. We got to focus on these guys because these guys got the problem, and we'll do something later with the other guys. Doesn't work that way. So lessons learned. Since I knew I wouldn't have the full 3 hours, anyway. No one city or one institution or profession will solve the problems we face. We got to get out of silos. If you always do what you've always done, you already get what you already got. Didn't we have a lieutenant governor who ran on that? Anyway, what is publishable may not be relevant, but what is relevant can always be publishable. You know, I can fill this building with sickle cell anemia stuff and infant mortality stuff, and I often say, you know, Chairman, close your eyes, close your ears, close both. Chairman can count, but they can't read. That came about because of Sputnik. Okay? We had a whole lot of money dumped into science. We had a whole lot of PhDs. We didn't have any place to put them, and so we put them in warehouses called postdocs. And the only way that we could distinguish between postdocs who come out of the warehouse and stay in the warehouse is count. A true change in the paradigm is needed. A true change. A person's perception is a person's reality, whether real or not. If I believe I can't get in a hospital and they can put all the signs, neon, and anything out there and say, welcome, they're not going to come. I had an incident where a radio station made a mistake. I was doing an advertisement for a screening program, and someone inserted the word free. And so it was all over the radio waves. And I got phone calls from the leadership of MD Anderson said, we just heard this radio announcement and they said free. We're going to be inundated. I said, they're not going to show up. He said, well, you said free. They're not going to show up. We had 6 people. If a person believes that it's not free, and you can say free all you want, or they feel that they're not going to be receptive, they're not going to show up. They didn't. Okay. If the problems are in the community, then the community must be involved in determining solutions. Need to be at the beginning, at the middle, at the end. They need to be involved in the designing of the project, how the project is implemented, and then discussing the results. If you attempt to address the issue as a single problem with just one disease without taking into account other factors, you've already failed to address the problem at the beginning, and the outcome is like placing a Band-Aid on a heart attack. Make you feel good, but what about the patient? Okay? As we shift in terms of the demographics of this nation, we're shifting in terms, I tell people when we do clinical trials, we're looking for the healthiest black person in the world with one disease. And then you say, I can't find them. Nah. You know, I could give lectures on all of these. You know, to me, the solution of the problem revolves around these 6 key words. Trust, respect, partnership, communication, flexibility, and knowledge. Uh-oh. Okay. That's why I had 300 slides. I duplicated it somewhere in here. I published this. I sent this out for publication. The italicized words are the words that I changed. The journal sent back to me that they said this was the most insightful publication that they've seen in years. It was the only publication that I didn't have any change in, changes in words, phrases, whatever. I had to withdraw it because I plagiarized it. So I worked out a deal with the publisher that I wouldn't tell which journal it was, and they wouldn't prosecute me for plagiarism. The words I changed was black and Houston. This is the person that published it. Okay? And he published it in 1899. And the words I changed was Negro and Philadelphia. That's the only words I changed. So how far have we come? How insightful are we? Try not to become a man of success, but become one of value. We can't solve problems by using the same kind of thinking we used when we created them. And I basically said, how can we expect solutions from those who benefit from the problem? It is in their vested interest to continue the situation when they are unaware, and sometimes aware. What the impact will have, they live for the moment and not for the future. Most individuals are like CEOs, as long as the company is doing well, increasing, then why should I worry about once I step down? This is a person, most of you probably don't know who this person is. I'm of the age, and a few of you in the room are of the age, you should know who this person is. This is Mom Smabely. She was one of the first black comedians on TV. She used to come on with a mop. She's the one that said, if you always do what you already done, you already get what you already got. I got the phrase off a bathroom wall in New Hampshire. And I thought it was written by an anonymous person until I gave a talk and someone said, hey, that was written by Mom Smabely, and I tracked it down. It actually was written. But it says, unfortunately, when we approach efforts to deal with the real lack of progress in addressing health disparities, we tend to fall back to what we've done before. It may be under a different name or packaged in a different box, but ultimately, it is the same strategy. Healthy People 2000. Healthy People 2010. I was involved in Healthy People 2020, and really, I thought we had learned, because originally it was going to be Healthy People USA. There wasn't a number at the end where people would expect a change. But we fell back to the same thing as Healthy People 2020. We're now in 2013. We got several more years, and we're now thinking about Healthy People 2030. You know, unlike this statement, this monument, I find that I tend to honor everyone, but I also insult everyone, because it's us. We're allowing this to happen. I say, you know, we're all insane. You know, we continue to do things the same way and expect a different outcome. We do it over and over again, and we think things are going to change, and they don't change. Yeah. Okay, immigration. Ah, I did make it to that. A few more minutes. Okay. Between 1792 and 1965, 85% of all the people who came to America's shores were from Europe, and they were from a specific part of Europe. The doors weren't open for Greeks. Doors weren't open for Italians. You had to be English or Northern European. So it wasn't all Europeans that were able to come to this country. But I make the note that a poor white man who ended up in the White House, Lyndon Johnson was a poor guy. His playmates were black. Okay? East Texas. Okay? He ended up in the White House, but he made a strategic decision that has changed the faith of this nation forever. And that was his support of the 1965 Immigration Act, which opened the door. And I tell people, you know, we can build gates, we can electrify the border, we can do everything. You know, we can build big boats, we can put it with piranha. This nation is forever changed. We have more people of color being born in this nation than immigrating to this nation. So the door has been open. The fate has been changed. In Houston, you know, we're now a majority-minority city. There's no majority of any individual, okay? We're still struggling with it in terms of making it happen. Health is not a priority. Well, look, here are the determinants, and here are how we spend our money. Okay? I put this up. I could give you $2,010, but if I did, I would be so depressed that I would leave and not talk to you anymore. So I'm trying to stay positive. I just keep it to myself. But I think about it. And I'll give you some hints. Okay, basic education for all, $7 to $8 billion. Okay? That really hasn't changed that much since that number. It's gone up somewhat, but it's still around that number. Cosmetics in the US, at that time it was $8 billion. Today it's $17 billion. So is health a priority? We spend twice as much on cosmetics today than we spend on education. Think about that. And I can go through the others. Ice cream in Europe, you know, reproductive health for all women. Ice cream. Dog food. You know, think about that. Dog food. So is health a priority? Here's, so you know that here's infant mortality. Straight line, basically. The problem is, if we look at it today, that line has gone like this. I don't put it up because it depresses me as well. It's now 2.6. Okay? So a nation that doesn't care about the most innocent, and, you know, how do they care about you and your health? We don't ask that question. You know, we kind of sit back and say, well, yeah, how much does it cost? You know, oh, I'll put this up. We've now calculated that over the next decade, health disparities in this nation will cost this nation $5 trillion. A little over $5 trillion. Okay, $5 trillion. Heard that? $5 trillion. What's the debate in Congress? How to cut the budget $1 trillion. Address health disparities by 20%. I didn't say 25, I didn't say 50, I didn't say 100%. 20%. Only 20%. There's your $1 trillion. No custody defense, no custody education, you know. And then doing that, think about the outcome on the other end. The healthy individuals you get who will be productive to society and won't cost any more to society. Yeah. You know. Is it real? Tons of books, you know. Tons. I've been involved in that. But 68% of Americans, 63% white, say it's not a problem. It's minorities not going in for care. It's their problem. It's our problem. It's an American problem. Okay? Race is a biological construct. There's no such thing as race. There's one race. The human race. If there are different races, we wouldn't be able to propagate with each other. This room would be in the different complexions it would be. Okay? Do you know anything about biology? How do you find, 1790, free white, other slaves. So where were free blacks? Where are they counted? In this number. Okay. And then we've gone through and reclassified it, mulattoes, we got down to 1890. Quadroons, octoroons. What's a quadroon? 1/4 black. Octoroon? 1/8. Percy was 1/8. Percy looked like a white man on the bus, on the train. But someone knew his family history. And they said, you're black. You gotta get off the bus, get off the train. Yeah. OMB 15. What does this last line say? These classifications are neither scientific or anthropological in nature. But how have we been using them? Clinical trials, black people will do this and white people do that. And, yeah. Okay. And then I say the Heinz 57 variety. People may identify more than one race. The black population in Atlanta went down. And they didn't move. Cancer rates went down for blacks. It went up for multi-race people. And they said, we made a difference. These definitions. If you go to medical school, nursing school, health professional schools, you will see one of these definitions. The one in red is the one I like the best. A vague, unscientific term for a group of genetically related people who share certain physical characteristics. What's wrong with that? Perfect definition, right? How can you be unscientific and genetic in the same word, in the same sentence? I'm waiting for an explanation. There must be an explanation because it appeared in a $450 textbook. They must have given a lot of thought to that. It's an oxymoron. Heard of the one-drop rule? One drop, you're black. I have a solution to a racial problem in this nation. I go to Africa and I get enough blood from the blackest person I've seen and come back and give one drop of blood to every white person I've seen. That's one drop, right? That's what the law says. One drop of Negro blood. That's in the law. I tell my friends that if you're Asian and you're born in Georgia, you're black. That law is on the books. They just haven't enforced it yet. The law is still on the books in Mississippi. If you're Asian in Mississippi, you're black. That law is still on the books. That's why a lot of Asians moved to Texas. Because crossing Louisiana changed them genetically to white. Virginia, same thing. We think that in our history books that the majority of slaves that came to this country, came here. Only 5%. 95% went to other areas. And we think that they came because willy-nilly. They actually were deposited in areas because of their skills and trade. Okay? If you track how they came out of different parts of Africa, they were deposited in different areas because of their trade and their skills. Okay? Who is he related to genetically? Him? 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 Or him? It's a real question. Because we say, he's the first African American president. Well, his father was from Africa. Yeah, okay, that's good. But is he truly, by definition, in the United States, African American? No. Why is that? He's probably more related to him, and not because he's black, as well as him. And it's anthropological. Because the origin of most whites came along this lineage in terms of the genetic population that came out of Africa. Slaves came out of this area. Okay? Whole genetically different population. Africa is one of the most genetically diverse populations and most genetically diverse continents in the world. So, we assume that because slaves were brought over, so somewhere in the Middle Passage, God laid hands on them and made them all genetically alike. All speaking the same language, all having the same culture. I mean, that's what we assume, right? That every black person can dance, right? There are 3 points of entry. Chesapeake Bay, Carolina Coast, Mississippi Delta. Okay? Ever wonder where the blues came from? It came out of Mississippi, right? If you play the Muslim call to prayer, the basic Muslim call to prayer, and the blues, they're identical. That's because a large percentage of the slaves that came into this area were Muslims. People say, oh, they were unreligious and not slaves. No. Remember, I said they came with trades. Okay? Came with background. See, that also lends itself to different languages, different disease patterns, different cultures, the whole bit. Okay? The guys in North Carolina, in terms of their origin, are wholly different than the guys down here. If you meet an African American in Washington, you can almost distinctly, just by looking in action, know that their origins are from North Carolina and not from here. The same thing in terms of Texas. Okay? In terms of when Katrina guys came over, you knew the pattern because there was a certain group that actually moved. Okay? I'm not saying that disease doesn't occur in terms of prevalent differences, but I'm talking about populations, not racial groups. Populations and how we define populations. I'm also saying that it doesn't convey certain issues with regards to populations. For instance, African Americans as a race, and this is an abstract, I wouldn't have used that term, was associated with a 17% survival disadvantage as a group. Okay? But that may not be the same in terms of other populations. Genetically, okay, this area is known as a stroke belt. Stroke belt for both blacks and whites who have origins from this region, okay? This area of Africa has low salt content. All of the rich had salt, okay? But if you know anything about the history of the United States, this area of the United States had very few white women for a long period of time. Men are not celibate, okay? I say Strong Thurman maybe didn't know he was black. Probably did. Because he said he was one from the original people who settled this region. Well, where was his grandparents, great-grandparents? Where did they come from without any women? There are only Native Americans and slaves. And there were more slaves than there were Native American women. Think about that. Maryland is a Catholic state, okay? That's important to remember because most of the white women who came into Maryland were Scotch-Irish. They came over as indigent servants. Their places were close to the African slaves. A large percentage of them had relationships or married African slaves. And I jokingly say if you were bright enough, you became white. And you were dark enough, you kind of went the other way. But to show you how this genetically relates, this is one of the highest incidences of premenopausal breast cancer in the United States, both black and whites. If you go back and look at the region where they came from in Africa, the highest incidence of premenopausal breast cancer comes from that region. So there are genetic relationships, but not racial relationships, population relationships. Okay, which one of these guys is black? It's got to be him. The angry black male. Happy white male. I mean, perceptions. Okay? These are all black women, including her. She's not black. She doesn't have those features. Wait a minute. Let me look at the nose. Okay? If she were to walk into your clinic or for healthcare, what'd you say? Asian. Immediately can't be qualified for Bidil because Bidil is a black drug, right? How about her? You've seen her on TV, right? She's Afro-Caribbean. Okay? By the one drop rule, he's white. He's got a lot of drops. You must go the other way, right? You got, you know. Yeah. I stopped putting his name up. He's a good friend. He says, yeah, you've talked, and I know where you've talked because people come up to me and say, you're black. A lot of black drops here. You know why this is the case? He's Scotch-Irish. He's one of the guys that his family went the other way. He announced at a family Thanksgiving dinner, you know, the genetic patterns and was circulating it. There are a lot of family members that do not come to his house anymore. He hasn't changed. You know, we use all this for a proxy for race. You know. And how about racism? You know, race, perhaps the single most defining issue in the history of America. You know, we're still with it. It hasn't changed. Unequal treatment. Even when they control for everything, they found race played a major difference in terms of how care is delivered. Who you are equals what you think. Do you think the average black person is better off, worse off, just as well off as the average white person? Look at the differences for each of those questions. Perception. Whether it's real or not, it's perception. And you have to address the perception to get to the reality. So what's different in this? You know, Harold Freeman said, in our society we see, value, and behave towards one another through the powerful lens of race. We've been conditioned to do that. Race still matters. What if I were to tell you that these were an hour apart? He went into the grocery store an hour before this person in the same store. Okay. Let me add also, he was a freshman at Xavier. They were sophomores at Tulane. So I guess he was looting so they could find. I asked the reporter, I said, why was this guy looting? He says he's black. Perception. Who's uninsured? Most uninsured in the country are white. Between ages 19 to 39, have children, household incomes between 20 and 60,000, work in small businesses. Okay? Not your perception. Okay? Unconscious discrimination, when we hold a negative stereotype about a group and meet someone that fits that stereotype, how do we react to it? Good friend of mine, Dave Williams, did a Tupperware party in which it was all whites. And he had his assistants ask these questions. Lazy. How many of you think black people are lazy? 44% said they thought people were lazy. Only 5% of blacks. Violent. Let me stand behind the podium. 51% thought people were prone to violence. Unintelligent, 29%. You know, I add those two numbers together because if people say neither, I think they lean towards the other. Yeah. Hispanics feel no different, except they were more workaholics. You know, less likely to be lazy. Okay. I wonder how he feels about OG. I wonder how he feels about Farrakhan. I wonder how he feels about affirmative action. You know, when I'm in the lab, people generally go to my lab tech, most of them tend to be white, and say, I have this product I want you to buy. And they say, I'm not the one, him over there. Perception. If you have a chance to get this book, this is an important book. This was written by a reporter, and it's done a lot in my lab. I give it to most of my postdocs that come in. I didn't at the time, but I now do. Because I had this fierce battle that was brewing between one of my white postdocs and one of my black postdocs. And I was trying to figure out what in the hell was going on. And so I called my black postdoc in and I said, what is going on here? Oh, Kayla doesn't like me. She's done a lot to me. I said, what'd she do? She not collaborating with what? No, she does this. I said, what? Well, she does this. She said, you know the hair thing. She's telling me I have bad hair. I pulled out the book. I read the book. And then I went to Kayla, and Kayla says, she doesn't like me. I said, why she doesn't like you? I don't know. It's a black-white thing. I said, what black-white thing? I don't know. She just doesn't like white people. It was a hair. Simple thing. They're now best friends. But it comes about because of white privilege and how persons of color interpret this. Like any social phenomena, it's complex. In a white supremacist culture, and we still live in that, make no doubt about it, we still do. All white people have privilege, whether or not they are overtly racist themselves. There are general patterns, but such privilege plays out in different depending on the context and other aspects of one identity. And this was written by Bob Jensen when he was an assistant professor. And I decided I was going to play with Bob. I said, Bob, I'm going to educate you about not doing this as an assistant professor because you're jeopardizing your tenure. You know what Bob said to me? He said, Lovell? He says, if I can call you Lovell? Okay, can I call you Bob? Well, Lovell, you have to realize I'm white. I'm often forgiven for things that I do in error. I said, what? He says, yeah. Fast forward, Bob is now a full professor. Bob wrote an editorial that appeared in every major newspaper in this country about why the U.S. deserved 9/11. If I had written that editorial, I would not be standing here today. Bob is still on the faculty at the University of Texas and a full professor. It's how we interact with others, what we can say and how people think we say it. What are the solutions? I didn't think about it. George Engel, when he looked at psychiatry and dealing with psychiatry patients, he said, you just can't deal with the disease. You got to deal with all the factors that impact the disease. Family, sociology, health, all of those come into play. And so I decided to do that with health disparities, health inequities in terms of addressing the issue. As part of the Institute of Medicine, I came up with these 3 guiding principles. A coordinated effort is needed to improve the collection and coordination of health information to better link this data to specific populations and communities of color. Research that related to health disparities should engender 3 principles: improve the science base, involve the affected population, and communicate the finding to all stakeholders. A friend of mine published an article on Tuskegee, and then published one in terms of what it is to do an appropriate community-based research proposal. There are 8 signature things that you're supposed to do, and I forgot to put them in here. But I'll tell you, Tuskegee did not violate any of them. Tuskegee did not violate any of them in terms of how it went. In instances in which the science is incomplete with respect to health disparity issues, it is urged that those involved in such research exercise caution on the behalf of the affected population, particularly those that have the least access to medical, political, and economic resources, taking reasonable precaution to safeguard or minimize adverse health outcomes. We don't do that. The National Children's Study does not do that. Think about it. You're going to follow these children from birth to 18 years of age. And the biggest thing is that you're not supposed to intercede in anything that takes place. How different is that from Tuskegee? That's the question I ask. I used to be on the advisory board. I'm not on the advisory board anymore. Because I keep asking that question. How different? Yeah. These are the coordinated efforts that came out of the Institute of Medicine report. If you want a copy, I can give it to you. I know I'm time?
Getting close.
Getting close. Okay. Here are the things. Tell me when. Here are the three things I think are needed: education, health policy, research, and collaboration. This is what I've done in terms of biennial symposium, which is education, educating a population. Intercultural Cancer Council, which is the largest health policy organization, multicultural health policy organization in the country. And then the Dorothy I. Height Center, and doing this with a Health Disparities Consortium. And that consortium now has 38 institutions, in which Texas A&M is one of them, both the Health Science Center, which is now becoming part of Texas A&M, as well as Purdue and Purdue's College of Nursing. If you want to get more about this, we have a workshop in the summer from June 17th to June 23rd. That's going to be held at Purdue and the College of Nursing. I call it a happening. We also have launched the first genomics course several years ago. That's probably now on other campuses in terms of the human genome on the Purdue campus. And it is the first course that was actually teleconferenced from a historically black college and university to majority institutions across the country. And we have a who's who of people that come in there. The consortium has allowed us to do the Secure project, which looks at health disparities in terms of disasters. The traditional model of health and health research, you notice, researchers get money, projects, contact community data, all that. Where's the community benefiting in this? This is a new model that we have enacted, and you notice the community benefits from a lot of this. We call this looking at a biopsychosocial approach. And what is a biopsychosocial approach? It acknowledges all possible influences that might affect health and the quality of health, both positive and negative. It is the understanding that health cannot be addressed as a single issue, that has to take into account other factors that influence the perceived need for health care and the attention to health concerns, housing, economics, all of those issues that play a role. It is to take all of these groups and make health outcomes, not publications, not grants, but health outcomes, the centerpiece. If you do that, you'll get the grants, you'll get the publications. It takes into account all of these factors that influence an individual and group's health or health disparities. It is to organize these into core units so that you notice that the community is still at the center of this in terms of that. It is to take the community relations core in terms of the framework, in terms of community, research, and partnership that addresses health disparities. Our community, and you notice it's community relations. We don't do community outreach. When we did community outreach, the group in the community said, where's your institutional inreach? Because you need as much inreach as we need outreach. This is a picture from one of the studies that we did. We launched it in the Family Cafe out in the community. Here are a list of partners, true partners and collaborators in terms of what we do. There are 5 elements originally written for establishing an effective cancer education, and I would say health disparity program or health equity program. It is to state that a committee which plans to provide programs should include persons who represent populations targeted to be served, not the minister, because he probably stays next door to you. Not the business guy because he probably stays next to you, but someone who really is into the community. Major items should refer to your local cancer and health plans. If one doesn't exist, one should develop one before you start. That's the issue of local data. Use a wide range of health, education, communication methods to capitalize on the strength of each. Ebonics is a language. It is a language. If you talk to linguists, they will tell you it's an African language. It's a dialect that's been carried over from Africa. The need for a procedure and or instrument to measure success. You need to know how you've succeeded. And then the need for sufficient funds and manpower to carry out the plans. If you don't have it, don't start. I always violate that one because I never have enough money. What you want to do is build this from the inside out so the community becomes the owner of the project so that when they tell you they don't need you anymore, that's the best words you can ever hear. NCI and CDC refers to it as endemics. I won't go through the study other than to say, this is a project focused on breast cancer in 25 to 45-year-old African-American women. What's unique about this? You notice that all the women here are between the ages, most of them, are between the ages of 25 to 45. Okay? And the reason why that's the case is that when I ask them to do something, they don't ask me, why do I have to stay this late? Because it's to their self-interest that this succeeds. That's not to say that you have to have all African, and you notice they aren't all African American. We've developed a program in terms of patient navigation. I talked a little bit about this with regards to some of the graduate students I met. But the key to this is this program that I found that actually pays for indigent care. This program has brought $6 billion to MD Anderson over the last 6 years. Because there's no such thing as not finding care or money for people. It's just that you don't look and you automatically educate people along that. We do science, kindergarten through 12th grade and postdocs. These are now individuals that are in middle school. They're tearing middle school up, okay, scientifically. This is Bernard Harris. Where? Let me find her. Here she is. She went up to him and she said, do you know how many bones there are in the body? He said, wait, what? Is she a midget? I said, no, she's asking. She's a 5-year-old. She's asking you the question. He says, well, how many bones there are in the body? She says, 205. You know about phalanges and on the fingers? He said, whoa. He said, I didn't know that until I was in middle school, high school. She's on free lunch. Okay. This school became the first elementary science academy in the state of Texas. 80% of these kids are on free lunch. Roughly 90% minority. Okay. They went from 19% passing a science tax to over 90% passing a science tax with 36% commended. These are all labeled dumb kids. They aren't dumb kids. These are all my high school kids. Some of the reasons I went back, because you notice, isn't any black male in this picture. That's why I went back to kindergarten to start working, because we lose 80 to 85% of our kids between the 3rd and 4th grade. All kids. Okay? These are the guys that do the work. These are my postdocs. When people walk in and look at my postdocs, they go, are these all postdocs? Yeah, they are. Where did you find them? They found me. These are all my mentees, some of them, not all of them. There's Rick Kills right there. That's Genesis to the Stars. Let's see on here. You should see.
Is that an old picture of Dr. Guidry?
That's an old picture of Dr. Guidry. That's when he was with me. Yes, that is an old picture of Dr. Guidry.
Okay, point that one out.
Huh? Most of these guys are at major institutions across the country. Okay? They're not in Texas. And that's the problem I have. Okay? Because when I started this, it was to change the diversity in Texas. Okay? But they're doing well. And the reason why I'm doing this is these 3 guys. These are my grandkids. That's me, you know, for the rodeo. And that's my oldest grandchild for the last rodeo. So if you want to change the world, you got to be that change, you know. But you have to remember, do one brave thing, then run like hell. Because somebody's going to be after you. Remember, no matter how hard you work, no matter how right you are, the dragon wins sometimes. You just got to stay at the dragon's mouth. You know, that's what I'm always doing. But I believe that we have a voice inside us that tells us what is right and wrong. How we listen to that voice and act on it produces the people we are. And so, I'm open for a few questions if we have time for questions. If not, thank you.